Welcome to the Nursing Post podcast, all nursing all the time with Ashley Moore and Rosa Horsley. In this episode, we discuss hypertension, also known as high or elevated blood pressure, and stroke. Because May is Stroke Awareness Month,
our goal is always to inform, help, and start conversation.
So blood pressure is known as a silent killer because you can't feel it.
Yeah, you usually don't know that you even have it.
So because of the fact that you don't know that you have high blood pressure until usually it causes some kind of problem or
other issues come up, yeah.
Right, or you go and get it checked at a routine physical or maybe like a health fair or something like that. You just don't know it's elevated.
Yep. So what blood pressure actually is, because everybody hears this number, it should be, it used to be 120 over 80 and now they want it less than that, 110 over 70. So it's very important to actually know what blood pressure is.
Yes.
And so what it is, when your heart beats, it creates pressure that pushes the blood through your arteries and your veins.
Yes.
Your whole network there of blood vessels. This pressure is the result of two forces. The first force occurs as the blood pumps out of the heart and into the arteries that are part of the circulatory system, and that's the systolic pressure. That's that top number.
Yep.
And then the second force is created as the heart rests between the beats, and that's that bottom number, the diastolic pressure. So it's important to know, which does what.
Right, because is it the force too much when it's first coming out, or is your heart not really getting a good chance to rest
between each beat? Absolutely. Right. So there are risk factors that are associated with high blood pressure.
Yes.
And of course, one of the most common is that your blood pressure reading is elevated, not just one time, but several times over a course of time.
Right. So when we say high blood pressure, there can be one-offs. If you're maybe in a lot of pain, that can elevate your blood pressure. But then when the pain's gone and goes down, that's not really what we're talking about here. No. We're talking about your blood pressure being high over an extended period of time, no matter your location, doctor's office versus home.
Correct, because some people do get white coat syndrome, and every time they pop up at the doctor's office, their blood pressure is always over, 120 over 80. It's never perfect, and that's anxiety.
Yes.
And sometimes stress causes elevated blood pressure, but it's not necessarily chronic. It's
acute.
It's acute. So age plays a big factor in this, and I feel, because this is my opinion, but after everything that I've had to read up on, I feel confident enough to say that everybody at some point, if they live long enough, is going to have some type of degree of high blood pressure.
Everybody in industrialized populations will have that.
Yes.
There was a great article that the people who do not live in industrialized populations don't have that correlation.
I think that's that namaste effect.
Right. I think it's we're not eating all that crap.
Yeah, that's true. That's true. That's also true.
Yes.
Ethnicity plays a big part in this.
Yes.
Studies have shown that Black Americans and Latinos have a higher risk factor for hypertension. And they're not the only ones. Asians, Pacific Islanders, American Indians, Alaska Natives, they tend to develop hypertension, earlier in life.
Right, compared to white people, yes.
Yes.
So the idea being that we're probably all going to get it no matter your ethnicity, but if you're anything but white, that's going to happen sooner.
Rather than later.
Probably happen sooner, I guess is the better word to say. But reading article after article after article kind of puts you more to that gonna versus probably side, in my opinion.
So let's say you're elderly, you've already had some elevated blood pressure readings, you're not white, and now you're smoking.
You're in a bad situation. I would say that if you're not white, you just check the box, like one of the biggest boxes of, am I going to have high blood pressure? Yes. And then after that, as you advance, I think over the age of 65 is what I had read, that's really when it starts to bump up.
Yes,
it starts increasing your chances. So 65, not white, oh man, that's 2 big check marks.
Now you've added a smoking habit to it.
So you might as well just say, I have it.
Hang it up.
you're a unicorn if you don't.
Yeah, that's absolutely true, because I don't know, when I think about it, one person that doesn't smoke, that doesn't have hypertension.
Right.
Yeah. I'm not saying that it's not the case, because I'm sure there are people out there that don't have it, but let me tell you, you've just narrowed your chance into almost the 100% that you're going to have it.
Right.
But that's because of the drug that's in cigarettes.
Yes, that is actually what I was going to say. So nicotine actually, it raises your blood pressure in your heart like a stimulant would. And because of that, it narrows your arteries and hardens the walls. So then there's not that flex that you need. And that also, because of that, it makes you more likely to clot. So when you have high blood pressure and your arteries are stiff from smoking, you're going to have high blood pressure, and eventually you can get to the point where one of the plaque that builds up that helps harden the arteries breaks off, and then you go into stroke or heart attack.
Yeah, that's a good way of describing it.
Yep.
So now I am elderly. I am not white. I smoke, and I also drink.
Yeah.
It's not looking good for me.
It's not looking good for you. It is not looking good for you. And at that point, I would just say you're a shoo-in.
Yeah.
You're a shoo-in. If you're white, you're almost a shoo-in, because you're probably going to have it. But just because you're Caucasian, there's this beam of hope.
That little one ray of sunshine.
And so that's kind of when you start compounding all these. And as healthcare providers, you need to understand this.
This is important stuff. This is like things that you should be in your nursing brain.
Yes.
Thinking about your patient, like, man, they're already at risk.
Yes.
And now look how many times.
Look at all these other risk factors, and we're checking all these boxes off. So at that point, you need to say, okay, if they're having any symptoms related to a heart attack or a stroke, I need to be on this.
On top of it.
And I need to be treating appropriately, efficiently.
Fast enough, yeah.
So that way you can actually make for good outcomes. So these are all those things that you have to think about when you think about risk factors and patients coming in, or you're triaging them, or whatever the case may be.
Alcohol use, that's, more than 3 drinks in one sitting, temporarily increases your blood pressure. But just imagine you're doing this daily or a couple of times a day, because some people do that. And so repeated drink binging, I guess, for lack of a better word, it leads to long-term blood pressure increases. Okay. Right. It's 2 drinks a day for men that are younger than 65, 1 drink a day for men over 65, and 1 drink a day for women of any age.
Right.
A lot of people don't know what a drink is. I'm not a drinker. So this to me is pretty interesting. 12 ounces is a beer.
Right.
5 ounces is wine.
Not a full glass,
5 ounces. Yeah, not the rim.
You don't fill it to the rim.
Yeah, we're not filling her up.
That's 1 glass of wine.
And
no, it's 5 ounces.
And it says 1.5 ounces of 80 proof distilled spirits. And I'm not going to lie, I'm not a drinker. I don't know what a distilled spirit is. I don't know what that is. Are they trying to communicate to me from the other side? I don't know.
Honey, that's a shot.
Oh my
That's
God.
what we would call a shot.
Why did they just say shot? Yeah, I'm like, I don't even know what that is.
Oh, goodness.
But I think what I can tell you for sure is that alcohol has a lot of calories.
Oh, it's sugar.
It's sugar. The body loves sugar.
Oh,
It'll hold on to it.
I love it.
What's that saying? A moment on the lips, the lifetime on the hips.
Oh yeah.
Like alcohol is calories, and it will explain a lot of weight gain. If
absolutely.
You're drinking every day,
and especially in
excess.
Yeah,
absolutely.
Because they're probably still having dinner.
Yes, and every other meal that goes along with the day, yes. And we all know that weight gain puts a stress on your heart, and how effectively and efficiently it pushes blood flow throughout your body.
Right, and if you're consuming all this, and you're gaining weight, and you're eating all this sugar, drinking sugar. However you want to look at it, consuming it, my mind goes to, honey, you're finding yourself a one-way street to diabetes.
Yeah, and hypertension. Now you got a 2 for 1.
So now all these things start compounding.
Yeah, it's a 2 for 1 now. It just keeps compounding when you go keep going through the risk factors. Gender plays a big role in this.
Yes.
What did you learn in reading about this?
This is one of the things that I found interesting. I'm white, if that matters at all. So.
It doesn't. I love you anyway. It doesn't matter. I still love you.
So reading some of this stuff really opened my eyes to a lot and made me rethink, am I doing things right, justice by my patients? So I'm really happy that I read a lot of these articles. This is for gender, 8 to 29 years old for white adults. 1.5% of women reported hypertension, but over 5% of men. So men were at greater risk for hypertension than women. And then same age range for Black men and women were the same. The proportions were 4% and 10% respectively. So you're looking at men still had a higher, chance of getting hypertension compared to Black men versus Black women. Mm-hmm. So women kind of, you got a little bonus there. I don't know. Great.
A little leeway, I guess.
And then the men, their hypertension is higher. If you're a man, so I mean, really, if you get into this, start looking at some of these things, because it's nothing for me to see a Black male over the age of 65 who smokes or drinks.
Yeah.
That's a really easy thing for me to find in my line of work. And I'm sure that everybody else can say that as well. I mean, and not just Black, but
Hispanics, any person that's just not white.
Right. And so when I start looking at that and start thinking about all these people, I'm like, oh my goodness, you have to start reprocessing what you know.
And genetics, I mean, if your mother had it and your dad have it, and we go back to those squares that we learned in science,
right.
It's like who's going to get blonde hair and who's going to get blue eyes, or
right.
If your mom had it and your dad had it, chances are you're going to have it.
And then and I've always been interested to know, and I'm sure there's probably data on this, I just haven't actually dove into it. I wonder what part of that is actually genetic makeup versus all the learned behaviors.
Environmental versus genetic.
Yes.
That's something that gets me excited.
Yes.
That's so crazy, but it does.
So at that point, I wonder what of this is learned and what is not learned. And it's hard to unlearn what you've learned for the first 20 years of your life, because that's where you're most receptive.
Mm-hmm. That's when your habits are forming. Everything, who you are, is developing.
Which kind of leads right into the next, unhealthy diet.
Yeah.
A lot of that's learned.
It is learned behavior.
I mean, I learned to cook from my mom, who learned to cook from her mom.
Exactly.
So,
and her mom, and so on and so on. Sedentary lifestyle. So I think we all have heard and know what that means.
Yes.
I mean, to me, that's like being a couch potato, I guess. Yeah. Like the most exercise you get is from the couch to the fridge to the bathroom to the bed. Like you're not walking, you're not giving your heart any type of activity or exercise.
Right. I feel like 20 minutes a day, 4 times a week is really not that much.
No.
But to actually do it, I mean, do I?
No.
I don't.
I know I could be better at it.
So,
for sure.
And there's times that I do triage all day.
Yeah.
And then go home and I cook and I clean and help the kids with homework, but none of that is actually physical
activity, moving.
And then I sit on the couch and,
At least your watch doesn't yell at you.
No,
mine tells me to breathe, tells me to stand up.
I don't need somebody monitoring how unactive I am.
The struggle is real. The struggle is real.
So, some of the long-term effects of untreated hypertension.
Well, we know damaging and narrowing of your arteries.
Yep.
We know aneurysms can happen.
All that high flow to weakened areas.
Yep. It's kind of just pulling there, coronary artery disease, enlarged left heart, because remember, some parts of your heart are having to work a lot harder since those arteries are super narrow.
Right, and your heart's a muscle.
Yep, it is. Strokes, it's the number one cause of strokes.
Yes.
Dementia, because remember, people with dementia, less blood flow to the brain, their brains are abnormally smaller than somebody without.
Dementia is a diagnosis.
Yes. Kidney scarring, kidney failure.
Well, and there's a lot. I mean, we could have a whole episode
it goes on
on
each
just
one of these.
Explaining the pathophysiology of hypertension and how that works against your kidneys. I mean, your kidneys play a huge role in that. So that's like an automatic.
Yeah, eye damage, You know, a lot of people that have hypertension and diabetes have glaucoma.
And for men, this is a big one to help
I'm
keep their
telling you,
hypertension down.
Erectile dysfunction.
That is all blood flow.
I'm telling you, I was a urology nurse.
Whew.
I'm telling you, if these fellas knew when they were 15,
Get that blood pressure
they
under
wouldn't
control.
have been smoking and they wouldn't have been drinking. I'm telling you, they would have never rolled up into the office.
Right, because when people understand
that's a muscle that's flexed from blood flow.
it is a blood flow issue. You know, that's why the medicines that work to actually
Increase
blood flow. So there you go. So a hypertensive crisis is over 180 over 100. So you don't necessarily have symptoms. If you have that, I mean, some people get a headache. I mean, that's one of the big common ones that I've heard as a nurse. Like, man, my head is killing me. I'm like,
Let's check your blood
Let's
pressure.
check your blood pressure.
Yeah.
If you go, or if your blood pressure's checked, and
it goes away. It doesn't stay that high for an extended period of time.
No.
Yeah, it eventually will come back down. But then we have problems if it's associated with other things.
Right.
If you're having chest pain, if you're short of breath, back pain, numbness, weakness on, you know, your left side, any side, both sides, you have changes in vision like spots or it's blurry. Or even if you're having difficulty speaking.
Or saying words.
Or even comprehending what somebody's trying to say to you.
Right.
Then that's 911 emergency.
Right. And the reason why these specifically are so big is what we're looking at is heart attack and stroke. If your blood pressure's that high, it didn't just get like that overnight. It's been high for a while.
Yeah.
You probably have other issues
that are going on
that may not be treated. You may not even know that you have them. And then you have the atherosclerosis.
That's a hard one.
And a piece of that plaque has broken off and you're either having a heart attack or stroke. It doesn't have to completely occlude the vessel. It just occludes it enough to where tissue is still not being
supplied with oxygen.
And therefore it's dying and that is causing these issues. So that's why it's an emergency. And it's not a let's go to the ER. It's a 911.
Yeah, it's 911. It's not, come on, let's get in the car and take a ride down the street. No, it's you need to call 911 because in all actuality, literally every second counts.
Right. And what people need to understand is the people who are in the rescue squad have the ability to treat you on the way to the hospital. And then what they're also doing is calling report to the emergency room
to let them know.
So they know what's coming in. So
to be prepared.
There's a whole...
It's a chain of events. It's a series and a chain of events that happens that once you call 911, things are literally activated.
Right. And so when people go, well, I can get there just as fast in my car.
No.
Well,
you have to go through triage check-in, triage, and all that good stuff. So let's say you had hypertension.
Yes.
And now you've had a stroke.
Right.
One
of the biggest things, and you'll see this, I mean, this is on billboards everywhere.
Commercials now. It's even, I've seen it on commercials.
I don't doubt it. I try not to watch commercials. But it's fast. You want to act fast.
F-A.S.T. That's so important. F-A.S.T. Fast.
Right.
Fast. Because every 4 seconds, someone in the United States has a stroke. Every 4 minutes, someone dies.
That's crazy.
That's a lot.
That's
a lot. And stroke is the 5th leading cause of death for Americans, but the risk of having a stroke varies with race and ethnicity, which we kind of talked about with the hypertension.
Well, this all matches. Let's think about this.
Leads into it.
You're black or Hispanic or whatever. You're not white. And you have had long-term hypertension that's not been treated. And let's add something else in there.
I'm a drinker.
And you're maybe a little overweight. Let's say we're not diabetic yet, but we're just a little overweight. We're a drinker. We don't smoke. But your risk factors for stroke and hypertension
still
are already
increased. Yeah, they're already there.
And so when you're not getting adequate either health care, you're not going to the doctor, you don't understand, whatever the gap is there, you're not being adequately treated. And you end up with a stroke. That's a direct call. So to me, that these numbers match the hypertension, it's like, duh, of course they do.
It does. It makes sense. And it's the leading cause of long-term disability. And it's not just one stroke. There's like 4 or 5 different types of strokes. So this is Ashley's jam.
Yes.
And I'm going to let her get some peanut butter with it.
So there's something called an ischemic stroke, which is the most common. 87% of strokes are this. And what that is it's a clot.
Straight up,
it's a clot that is, there is something that is in the way of the blood flow. It's not getting where it needs to. It's a clot. To think about this, so 87% of this, the reason you need to act fast is because there is specific medicine.
It's time sensitive.
It's TPA. In the nursing field, we all know this. You can get this and it will dissolve the clot and return the blood flow to the area and leave you with minimal damage.
Absolutely.
That is astounding.
But it's time sensitive. I don't think people understand.
But you have 3-ish hours. I think some studies are maybe saying you can stretch that a little bit longer. We were already compromised going into this, right? Right.
So there's a very small, minute people that can have this TPA done up to 4.5 hours after the first onset of symptoms.
Right.
But if you have to think that's a very small gap because these are the uncomplicated people.
Right.
But we just said almost everybody is complicated.
Right. Well, and you have to think this through. So you have to have the symptom, notice it, and get somebody on the phone. And get to the emergency room through 911.
Yeah, not your car.
Not your car. Through 911 because they're already on it. And then you have to be scanned because we got to know it's a clot. Because there's a problem. If you give this medicine
to somebody who doesn't
to somebody who is having a different kind of stroke called a hemorrhagic stroke, which is a bleed in the brain, well, that's a problem.
If you give TPA to this because they're already bleeding,
maybe just kill them.
Yes.
So you have to know what type of clot it is. So you need to get there, get to the hospital, get a scan done of your head, and get this medicine administered within 3 hours. Of course, we just went over the hemorrhagic stroke, so that's 13%. So we went from 87% are from clots, 13% are from the hemorrhagic.
Do the math.
That's your two big ones right there. There is another stroke that we don't know what it is. Cryptogenic, I guess is how you say that.
Yeah, that's exactly what it looks
and
like. It's an unknown cause. Nobody knows why.
I'm like, why don't we just call it idiopathic? Because that's what we do in nursing, but whatever. And then we have brainstem stroke, which is the other little bit. And this is also a clot. It's just in a different area. If you add that into the ischemic, so it's still clots, they're treated the same way. The symptoms are a little bit different. So that's where you have to think a touch differently because the F.A.S.T, when we say act fast, F.A.S.T, we do that for a specific reason. The F is for face. So if you ask a person to smile if there's drooping or like drooping eyelids, that's a problem. So F for face. A, they can raise their arms up. So if they raise their arms up and they drift or they lower their arm, if they do it with their eyes closed, a lot of times they don't even recognize that they're doing it. So the A is for arms. The S is for speech. So you're looking for slurred speech, strange. If they say, I want a glass of remote.
Or they don't even understand, tell me your name.
Right.
Like they can't articulate
you say, tell me your name, and they say potato.
Absolutely.
And they can't get it out right. So maybe they're talking, it just is not right. Or it can be slurred, or it could be just complete gibberish. F for face, A for arms, S for speech, and T is for times. Call 911 because it's time sensitive.
Absolutely. Anytime you see any of these symptoms, it's time to call 911.
Right. And so the other part of the brainstem stroke is these are patients who have vertigo, dizziness, severe imbalance. Without the hallmark signs of stroke. If they all of a sudden are stumbling and can't walk, or they have double vision, or they're just not alert and oriented, that's a problem. That's a neurological problem. So that's what we kind of say, ooh, this is not right. So that's still an emergency. You still need to call 911 because we still want to act fast in that case as well.
Absolutely. There's been a change in that patient's norm.
Yes.
So it's anything that you're noticing outside of that patient's norm because norm is different per person.
Yes.
You have a standard, but everybody's an individual. So risk factors that increase your chances of stroke. We already talked about hypertension.
Right.
It's the number one cause.
These
High
look familiar.
cholesterol. What's cholesterol? It's buildup of plaque that's in your arteries.
Yes.
So one of those plaques just broke off and caused a stroke.
Yes.
So high cholesterol is increased risk factor. Smoking, which we talked about in hypertension, the rules still apply here. It's still doing the same exact thing that
Still
it did when
stiffening
you've
those
had
walls.
hypertension.
Yes.
Being overweight, being a diabetic. 1 in 3 adults has at least one of these conditions or habits.
Yes.
So
In the United States.
Yeah. Yes. That's pretty alarming.
And this is where, I kind of get on my little high horse.
Your soapbox, let me get it out.
Yes. Let me get it out. So you have high blood pressure, cholesterol, smoking, obesity, and diabetes. Minus your type 1 diabetics.
Yeah, they don't. I'm not talking
I'm
about
not
that.
talking about that. Okay, I'm talking type 2 here. These are preventable.
All of them, really. Yeah, all of them.
I mean, think about it. Can you lower your blood pressure?
Yes.
Can you get your cholesterol down?
Yes.
Absolutely. Can you quit smoking? Might be
Yes.
hard, but
But you can.
you can. You can lose weight.
It's
And
hard.
If you're type 2 diabetic and you do those other things, you'll probably get rid of
Rid
that
of the
too.
diabetes, yeah. Yeah. So we've already talked about some of the signs and symptoms of having a stroke. That's the sudden numbness or weakness in your face, arms, legs, or especially that one side. If I have a
that's
patient
kinda
that
classic.
comes to me and says, I'm numb on my left side and I have pain in my back, as a nurse, like all my little antennas go up and I'm saying 911.
Yeah. Absolutely.
You don't even have to tell me what the rest of your symptoms are. So if you're suddenly confused, you have trouble speaking or difficulty understanding what I'm saying, if you're having trouble seeing out of one or both eyes, you're having trouble walking, you're dizzy, you lose your balance, you're not so coordinated, or you just have a severe headache and no one knows, why you have this bad headache.
And that's kind of important because I think some people are like, oh, it's just a headache. But if you're having a hemorrhagic stroke, then that blood is leaking into your brain,
That's
and
not good.
that is causing an imbalance of the pressures and the fluid that's supposed to be in there naturally, and that's it doesn't make you feel very good.
No. So once again, you want to act fast. Early intervention with a stroke is vital because every second counts and makes a difference in whether a patient is able to fully recover or needs extensive treatment and or therapy. And my mom, she passed when she was 68. She had like 3 mini strokes, which are the TIAs.
Yes.
And then she ended up, having a major stroke and a heart attack, and it left her in a vegetative state before she passed.
Which is common.
We
see these TIAs are not
They're warning signs.
Got off good, I was lucky. That is a warning. A bigger one is coming.
It's a warning size and warning sign, and it's a big one. That first one, that's all the wake up call you really need.
Yes.
Early intervention, that it's so important.
It really is.
It's so important. Patients who arrive at the emergency room within 3 hours of their first symptom, they're offered TPA, which Ashley and I had spoke about before.
Yep, hemorrhagic strokes
Can be treated with surgical intervention to relieve pressure. That's a craniotomy, that's using coils and clips, and that's to control the bleeding.
Yeah, the coils and the clips will control the bleeding, and the craniotomy will relieve the pressure. But that's, again, these are things that they need to do. They need to do quickly.
It's quick. It's time sensitive.
It's this is what we would call a emergency surgery situation. With if you call 911 when you're in the ambulance, they're doing that at the hospital. They're forming those teams and getting that stuff together.
They're getting it ready. They're getting it ready. Most respondents, 93%, recognized sudden numbness on one side as a symptom of stroke.
Yep.
But only 38% were aware of all the major symptoms and knew to call 911.
Right. So even if they recognize I'm numb, I'm not working right.
Yes.
I'm probably having a stroke. Less than half still didn't get, I need to call 911 now. There was that delay. There are some clot retrieval devices that I thought were really cool. So maybe for patients who don't meet the timeline to get
The
TPA, they can go in there. So it's done with a catheter. It's a little tool that goes in. They follow the vessel to the clot, and they actually grab the clot and pull it back out.
Mechanical thromboectomy. Is that, I saw it mentioned in some of the reading, but I wasn't sure whether these would qualify as that.
I'm not exactly sure, but
It sounds exactly like what they would do. These just sound like different types.
yes.
Which is cool because science is advanced.
Yeah, I'd like to see once. I mean, I've seen a lot, but I've not seen that specifically. So we've kind of touched on this already, but wanted to go into some of the disparities with hypertension. And these align with stroke. So both hypertension and stroke.
Yeah, they go hand in hand when you think about
Yes.
them. Because one, if you prevent one, you can
Prevent the other. Yeah, naturally. It's amazing to me, but 20 years worth of research regarding hypertension and disparities, we still have a lot.
There's a lot that we still don't know. Like, we know that there's a correlation somewhere between non-whites not receiving adequate prevention, education, and treatment. But we don't necessarily know why that is.
Well, I think nobody wants to ask the big question, but that's just my opinion. But 43% of black adults have high blood pressure. So that's almost half. 29% of white adults have high blood pressure. And so, of course, they're still doing a bunch of studies on that. But some of the articles that I've read, even when you look at very similar histories, very similar timing to the ER, everything kind of matches as close as you can in medicine. So you have these two cases that are very similar. And let's just say one's a white guy, one's a black guy. Their treatment is not the same.
That's mind-blowing to me.
I just don't get it. Like, but why?
I think ethically we would hope that all physicians would treat, any medical person, whether you're a nurse, an aide, a doctor, would treat the patient, not the race or ethnicity.
That's what we would hope. But, I mean,
there's a breakdown somewhere.
We should be working now in 2020 on having everybody be educated on what high blood pressure is, what a normal number is, and what you need to do to get it down.
Absolutely.
Because if you don't, stroke. Okay, great. That's kind of very
cut and dry
and simple. Even at this time where we should be educating to bring those numbers down, Hispanics have seen an increase in deaths since 2013. That's in the last, so seven years. There's been an increase in death because of hypertension-related illnesses. So it's almost like we're going backwards.
You would think the more education there is out there,
the better
the numbers would be.
Right.
But unfortunately, in this case, it's not for anybody not white, it's just not true.
It's not. And after accounting for a lot of other factors that could affect treatment, including stroke severity, researchers have found that women and minorities were less likely to receive treatment, period.
I have a theory about this women. I can't tell you I have theories about the other disparities too, but that's like a whole nother thing. Women tend to carry a lot of hats.
Yes.
And I feel like as a gender, we tend to put ourselves on the back burner because we have to make sure, our significant other's taken care of. We have to make sure our children are taken care of.
And our
jobs. And I just feel like we compound so many things on top of us that we may not always put ourselves first.
Right. And so it was just kind of amazing to me because it said women had 8% higher odds of not receiving treatment than men.
If you postpone.
So I'm like, what the world?
If you postpone, that affects your results.
It does. It absolutely does. So it just kind of, to me, I thought that was a high number. And then I read that African Americans had 26% higher odds of not receiving treatments versus white, while other races were 17%. So
this is where I get baffled and confused.
Yeah. So if you're black, you have a 26% chance of not being treated. If you're anything else, you're 17. And then if you're white, then you're pretty good. I guess a white male, specifically.
Yeah, which is still mind blowing to me. And the reason why I'm kind of tired myself of hearing COVID-19. But let me tell you, out of all this that's happened, at least it's shining a light on the disparities.
Yes, because there's no way to look around some of this stuff. I mean, they said it on the news multiple times, that black men were dying from COVID when other people were not. Hello. So
exactly. Black and Latinos are less likely to seek life-saving treatments after stroke. I want to know why.
Right. Are they not given the proper education? Is it health insurance or coverage or cost? I mean,
transportation, anything.
I mean, we can get into a whole list of
reasons, but I want to know why. Like, we know this already. I feel like we need the information for future data, but let's not beat the same dead horse. Now it's an issue. Let's get to the bottom of it.
Right.
So,
and then 7% of Black or Hispanics received the mechanical thrombectomy, where 10% of whites did. And you hear 7 versus 10. Oh, that's not that big. That's
just what's captured in this study.
That's statistically significant.
Yeah.
So that would be considered significant in the medical field.
Well, if they're printing about it and writing about it.
Right.
Yeah. And that's, like I said, just the numbers that were captured for the study. It's not every case.
Right. And those with Medicaid or who were uninsured were less likely to get it than their white peers. So again, we're in the same boat again.
And this is also to me like mind blowing. You have government assistance with Medicaid.
Yeah.
Generally, one would think that it's zero copay, if not a very small amount of copay. I understand that hospitals and doctors' offices, what have you, may not receive as high of a reimbursement off of Medicaid than they would somebody that has Medicare or private insurance. But insurance is insurance.
Right. And
life is life, if I'm boiling it down even further than that.
It really surprises me just because I never look at a patient's insurance. I don't care. The only time I look at their insurance is when I'm doing something with their insurance.
Yeah, for their meds or something.
To help them, trying to figure out loopholes or what can we do. And I don't care what race they are, what ethnicity they are.
It shouldn't matter.
It doesn't matter to me. I treat all my patients the same. And I'll kind of look back at a lot of the patients that I have dealt with and thought, did I treat anybody different? Have I not done something for this one that I would have done for somebody else? And I feel really good about the decisions that I've made, but I wonder if everybody can say that.
I don't think everybody can. I think if they could, this wouldn't exist.
Well, not everybody's as wonderful as me.
That's true. Nobody's as wonderful, warm and fuzzy, Ashley.
Yes.
So, studies have repeatedly shown a difference in stroke care by race. Mm-hmm. That's what all these studies that we've read say.
Yes.
That there are racial, ethnic disparities in stroke care,
In most care, honestly.
Yeah.
In all care.
Yeah. I mean, all the studies say that. How do we fix this? That's like the $1 million question, right?
Honestly, I think that if maybe we looked at, and it would be sad, but maybe this is what we need to do, push through it. And I may not take as much offense to this because I don't feel like I'm in this category. So maybe if we actually said, something, are we making decisions and are we biased? And if the answer is yes, and that's what the problem is, then you can fix it. But as long as you keep trying to hide behind, oh, they probably didn't get here on time, or oh, they didn't take their medicine like this person did. You can't tell me that every white man does what he's supposed to.
No, that's
it's just not true. I work in healthcare. It doesn't happen. I know it doesn't. And you can't tell me that every black person is late and doesn't come into their appointments. But these numbers are so big. The gap there of treatment it encompasses everybody. And so maybe we just need to say, hey, maybe people are being biased. Maybe people are being racist. Maybe people are stereotyping. Whatever word you want to call it, you are not giving the same treatment to everybody.
To everybody.
And if that's the case, then let's take a really good hard look at it and fix it.
Absolutely.
Because that's the way you fix it, is by knowing what the problem is.
I think there are some communities that really aren't educated about hypertension and stroke. And, of course, early education leads to prevention.
Yes.
And, of course, when we're teaching health and other ed type of topics in school, this is something that I feel should be included from elementary up.
Right. But instead of saying, oh, you got to eat healthy because... it's good for your health and you don't want to grow up and get hypertension. Instead of looking and saying, hey, you're African American. Your chances of getting hypertension versus anybody else's is higher, and your chances of having a bad diagnosis or outcomes in the future is something that you need to take a hard look at. And if we start that in
kindergarten,
a very young age,
before kindergarten,
and not say, oh, we can't say that. No, we can, because we have facts and we have proof and we have this information, and by educating those kids, they now are empowered to make the change.
Absolutely.
To me, that's like, okay, that's not hard, let's do it.
No, that's something that we can all do. If they're teaching sex ed, we should be teaching children how to eat properly, how to exercise properly.
Yep.
I mean, and patients' rights. If patients know that they are entitled, because this is the only time I'm going to use that word, because I have certain bad feelings about that word, but if all patients realize that they are entitled to equal care,
yes,
then they need to stand up for that and know that and get that. Tell that doctor, tell that nurse, you're not listening to me.
And there are advocates that you can call. So if you're in a hospital and you're not getting adequate care, most hospitals, it may be all of them now in the United States, have a sign in the room that says, if you feel like you're not getting care, you call this number. And a patient advocate will come down and help you.
Yeah.
So those resources are there, but you just need to know that they're there.
If you don't know what TPA is, and as a nurse, as a not nurse, I wouldn't expect you to, but if you know that these treatments are available to you, the mechanical thrombectomy, TPA, blood pressure medications, if you know these things are available to you, then you know to ask. So that's back to the whole education part. The more you know, the better off you are, the more you can fight for your patient or, for your loved one's rights. Because if you don't even know this stuff is out there, how can you ask for something you didn't even know existed?
Exactly. Knowing what we know now, the longer that we live, the better the chance is that we're all going to end up with hypertension.
Yeah, at some point, I guess.
So I think that the most important thing to realize is that this doesn't happen overnight. It slowly develops and progresses over years. And so we can make small changes in our lifestyle today, and that will help postpone serious complications later. So make the changes now, so you have better outcomes. And with hypertension being the leading cause of stroke, those lifestyle changes and medication management, because sometimes it takes both, are essential.
Absolutely. Join us next week when we talk about healthcare in America. As always, we'll link our references to our website, www.thenursingpostpodcast.com. Be sure to subscribe to our podcast, and you can always follow us on Facebook, Twitter, Instagram, and YouTube. Thanks again for listening to The Nursing Post.